8 Signatures, Re-Architecting Healthcare with Patterned Ventures, in 20 minutes. Opening. Why we need patterned innovation. Healthcare is full of brilliance and broken systems. On one side, we have miracle drugs, precision surgery, AI models that can see things in scans even specialists miss. On the other side, we have patients crushed by cost, doctors drowning in paperwork, clinical trials that can't find participants, fake certifications that mean nothing, and data locked in systems that can't talk. What if we stopped trying to fix this with one-off apps and hero projects, and instead used patterns? Reusable innovation patterns, creative signatures that turn the same kinds of complexity into opportunity again and again. Tonight is about 8 healthcare ventures built from those signatures. Each one targets a different choke point. Each one uses a specific pattern. Canonical standards, pattern recognition, incentive design, network effects, distributed ledgers, marketplace matching, financial architecture, community governance. Together they sketch a different healthcare future. Still hard, still human, but more aligned, more transparent, and far more effective. Section 1. Med Standard Protocol, Teaching Systems to Speak Clearly. The first venture is Med Standard Protocol. If you've ever seen clinicians fax information from one hospital to another in 2025, you already know why this matters. Today, health data is like a room where everyone is technically speaking English, but each one uses a different dialect, different abbreviations, different ways to say the same thing. FHIR and HL7 exist, but every vendor uses them a little differently. What should be plug and play turns into months of custom integration. Med Standard doesn't try to erase those standards. Instead, it says, we will define the one clear way you are allowed to use them if you want true interoperability. It's a profiled standard plus a test harness. Strict rules for how patient meds, labs, allergies, and diagnoses must be represented. A reference implementation that vendors can drop in. A certification program that says, this EHR, this HIE, this API really does speak the language correctly. Hospitals and vendors no longer argue over how to map blood pressure for the 100th time. They implement Med Standard, run the conformance tests, and know they are talking. It's not glamorous. It's infrastructure. But without a shared language for data, none of the other 7 ventures can reach their full potential. Section 2. SymptoMap AI, remembering what no human can. The second venture is SymptoMap AI, a pattern recognizer for rare and complex disease. Doctors are trained to think, when you hear hoofbeats, think horses, not zebras. But sometimes it really is a zebra. The problem is that no doctor, no matter how brilliant, can hold 50 years of medical literature and tens of millions of patient cases in their head at once. SymptoMap doesn't replace their judgment. It augments their memory. Based on patterns and symptoms, labs, images, and history, it quietly says, patients like this, with this strange combination of findings, have sometimes turned out to have this rare autoimmune condition, or that metabolic disorder. Maybe consider it. Maybe order this one more test. In V1, it's not a robot doctor. It's a clinical decision support tool in a narrow specialty, rheumatology or neurology, say, embedded in the EHR. When a case looks atypical, SymptoMap surfaces a short list of possibilities, with reasons and references. The pattern here is tangible abstraction, taking massive, messy, abstract data and turning it into a small, concrete nudge that fits into the physician's existing workflow. As more rare diagnoses are confirmed, the model improves. As the model improves, it helps catch more cases earlier. Self-reinforcing accuracy, built gently on top of human expertise. Section 3. Chronic Care Rewards, making adherence feel good. Now, third, Chronic Care Rewards. A way to make doing the healthy thing actually feel good today, not just someday. Chronic disease, diabetes, hypertension, heart failure is where healthcare quietly spends an enormous amount of money just dealing with complications that could have been prevented. The science is clear. the pill bottles are full. But human psychology is not optimized for, if you're good for 10 years, you might avoid a stroke. Chronic Care Rewards changes the time horizon. It turns adherence into a game that pays off tomorrow, this week, this month. Patients earn points when they fill prescriptions on time, their connected glucometer shows stable readings, their blood pressure stays in target range, they complete short educational tasks. Those points redeem for things they actually care about: groceries, gas, online shopping, gift cards, experiences. Insurers and employers fund the rewards pool because every 1% improvement in adherence saves them many times that in avoided ER visits, hospitalizations, and complications. This is the incentive design signature. Not shaming, not nagging, but aligning dollars and dopamine so that what's good for the system and what feels good for the patient finally point in the same direction. Section 4. Trial Match Network. Filling the empty chairs. Fourth, Trial Match Network, a matchmaking service for clinical trials. Right now, most people who could benefit from a trial never hear about it, and most trials that could advance medicine struggle to find enough participants. Every month, a trial is delayed, costs sponsors millions. Every trial that fails to recruit wastes years of work. Trial Match builds a multi-sided network. Patients tell us who they are, or grant access to parts of their health record through trusted providers. Hospitals and research sites share which trials they're running and what kind of participants they need. Pharma companies and biotech pay to recruit the right people faster. An intelligent matching algorithm looks at diagnosis, stage, prior treatments, location, travel ability, schedule constraints, inclusion and exclusion criteria that ordinary people could never parse. Then it says, to a patient in a clinic or at home, there's a study within 30 miles of you, for people exactly like you, testing a therapy that might help. Here's what it involves. Here's what you'd be paid. Would you like to learn more? The pattern here is network effects plus multi-party coordination. The first 10,000 patients and 500 trials are the hard part. After that, being the default matchmaker for new therapies becomes an incredibly durable position. Section 5. Med Supply. Distributed, trusting every box and vial. Fifth, Med Supply Distributed. A tamper-evident ledger for medical supplies, counterfeit drugs, adulterated vaccines, devices that don't meet spec. These are not rare events. They kill hundreds of thousands of people and burn hundreds of billions of dollars every year. Current tracking systems are fragmented and easy to manipulate. Med Supply uses a distributed ledger, blockchain or an equivalent technology, to record every handoff. Manufacturer, distributor, logistics provider, hospital pharmacy, ward, patient. For high-value items, expensive oncology drugs, biologics, implants, each unit has a secure identity. At any point, you can see who made this, where it traveled, whether cold chain conditions were kept, which patient ultimately received it. If a batch is recalled, you don't issue a vague national alert. You press a button and instantly see which hospitals, pharmacies, and patients are affected. This is the distributed network plus audit trail signature. Everyone writes to the same tamper-evident log. No one can quietly change the past. Manufacturers sleep better because fakes are obvious. Hospitals sleep better because recalls are precise. Insurers sleep better because abuse is easier to see and stop. Section 6. Therapist Match AI. Better matches, better outcomes. Sixth, Therapist Match AI. A compatibility engine for mental health. Therapy is one of the most human, most relational parts of healthcare. But in practice, a lot of people experience it as, try one therapist, that didn't click, try another, maybe by the sixth we get it right. 40% of people drop out of therapy early, often because the fit just wasn't there. Therapist Match treats this as a matching problem. Patients answer a humane, non-clinical questionnaire. Do you prefer someone direct or more reflective? Do you like homework and structure or open-ended conversation? Are there cultural or language needs that matter to you? What's your schedule, your budget, your comfort level with telehealth? Therapists describe their training and modalities, the kinds of clients they work best with, their style and boundaries. The AI looks at patterns in past matches, which combinations tend to sustain 12-plus sessions or show strong symptom improvement, and uses that history to recommend matches with a higher likelihood of working. The pattern here is pattern recognition plus marketplace design. Patients pay little or nothing until a match sticks. Therapists pay a fee only when a new client becomes a long-term, healthy relationship. You move the market away from more leads and toward better fits and better outcomes. Section 7. MedEquity Financing. Betting on recovery, not debt. 7th. MedEquity Financing, rethinking how we pay for high-cost, high-value treatments. Medical debt is everywhere. People face $500,000 cancer regimens and decide not to treat because they can't see a way to carry that burden. Traditional finance says, take a loan, pay it back whether treatment works or not. MedEquity uses income share agreements instead. The rough idea: the patient pays nothing up front. Investors and providers finance the cost of treatment. If, and only if, the treatment works and the patient is able to work again, they pay a small percentage of their income over several years. If treatment fails or the patient can't return to work, they pay nothing. It's not magic, someone still funds the care. But the risk is now tied to real outcomes, not just procedure volume. Providers have reason to focus on long-term recovery. Investors have reason to pick treatments and centers that genuinely improve lives. Patients avoid the nightmare of paying for failure. This is the financial architecture plus incentive alignment signature. It's delicate, it must be regulated carefully, but it opens a path where access to care is based more on potential and partnership, and less on whether you have the right card in your wallet today. Section 8. Recovery DAO. Letting patients own the system. Finally, Recovery DAO, a community-governed network for addiction recovery. Traditional rehab is often a black box. Patients are admitted, insurers are billed, facilities are paid regardless of long-term outcomes, and relapse rates can exceed 75%. Patients have almost no say in how the system runs. Recovery DAO flips that. It uses distributed governance and tokenized incentives to let patients, counselors, and communities co-own and co-govern a recovery network. Facilities join as members. Patients and counselors earn tokens for sustained sobriety, peer support, participation in governance. Token value is tied to the overall health of the network, the proportion of people who stay in recovery, not just who complete a 28-day stay. Patients can use tokens toward housing deposits, job training, education, or healthcare. Facilities that show strong, long-term outcomes are certified by the network and receive more referrals. Those that treat people as billing units instead of human beings lose trust and standing. The pattern here is community capital plus governance. The people with the most at stake, those fighting for their own lives, finally have structural power over what good care means. It's not a quick fix. Nothing in addiction is. But it is a structural shift away from opaque, profit-driven models and toward transparent, patient-centered governance. These 8 ventures are not 8 random startups. They're a portfolio of signatures applied to a single, very hard domain: healthcare. MedStandard, canonical technical standard. SymptoMap, pattern recognition at scale. ChroniCare rewards, behavioral incentives. TrialMatch, multi-sided network effects. MedSupply, immutable supply chain ledger. Therapist Match, compatibility marketplace. MedEquity, outcomes-aligned finance. Recovery DAO, community governance and shared upside. You could build any one of them. You could build all of them, over time. You could discover new ones that use the same patterns in different corners of healthcare. The point is not that these exact companies must exist in exactly this form. The point is that we don't have to approach healthcare innovation as one-off improvisation. We can design with signatures in mind. Where can a standard remove friction? Where can pattern recognition surface what humans miss? Where can incentives be shifted so that everyone wants the right thing to happen? Where are there networks waiting to be connected, ledgers waiting to be made honest, markets waiting to be made fair, and communities waiting to be given real power? AI can help us see the patterns. People still have to choose what to build, where to aim, and how to share the value. For now, This work is still ours. Human work, human responsibility, human opportunity. If we're careful, we can use these patterns not to extract more from a broken system, but to build one where health, trust, and dignity have better odds. 8 ventures, 6 signatures, 1 overarching theme. Take complexity seriously. Respect incentives, design for trust, and build systems where doing the right thing finally becomes the easiest thing.